So I think, of course, in this day and age, mutation testing tends to be gold standard for most of our classifications, right? If you look at the classification of acute myeloid leukemia, a lot of this is done based on the genetics that are determined by mutation testing. And of course, some of them are, rearrangements that are detected by conventional cytogenetic methods. But I think we have to realize that, not everywhere has the resources, not all institutions have the resources to perform mutation testing. Even at places where we do have the resources to perform mutation testing, this is a technique that takes time. So, the fastest turnaround time may be around 3 to 5 days, and in some institutions it can take up to 3 weeks to get the mutation profile back. So I think there's still, value in using markers that are surrogates of mutations, like immunohistochemical staining for NPM1 or P53, for instance. And then, of course, the other issue, again, bringing up the menin inhibitors or other differentiating agents like IDH inhibition, is that when you use these agents, particularly in the setting of monotherapy, you can have residual mutation detected by, sequencing methods, but this can be in the differentiating cells that are ultimately going to go through apoptosis and die. So I think it's important to, again, have in conjunction another method that looks at morphology and flow cytometry and tells you whether these cells are differentiating or they're actually leukemic blasts. So there are still limitations to NGS, but of course it is the ultimate helpful tool in characterizing disease at baseline.